Hi students, topic for this week, discussion for this week will be evaluation of anemia. So we will be dealing with various types of anemias, what the patient will present as and what will be the questions revolving around in the upcoming NEET. Right, so the first type of anemia we'll be dealing with is iron deficiency anemia, very important. This is the type of nutritional anemia because it is predominantly due to deficiency of iron in your food intake. Now next question students around which the question is usually revolving is how the patient will present to you. So how a patient of anemia will present to you? Number one, the complaints will be fatigue. The patient will be getting tired easily, fatigue and tiredness, and paleness of skin. So these are the usual symptoms with which the patient will present to you, right? So complaint of fatigue and tiredness and paleness of skin. Now pointing towards the diagnosis of anemia in your patient. Next, what will you order? You will order for CBC and there you will see that the level of hemoglobin will be low. Very important in a case of anemia. The patient presenting with fatigue and tiredness, paleness of skin, the level of hemoglobin will be low. Next, what will you see? MCV and MCH. What will happen to MCV? Mean corpuscular volume. The normal value of MCV is 80 to 100 femtoliter. This is the unit. For MCV, here it will be decreased, less than 80 femtoliter. So can I say it is one of the differential for microcytic hypochromic type of anemia? Yes, definitely. 4 causes for microcytic hypochromic anemia are sideroblastic anemia, iron deficiency anemia, thalassemia minor, and anemia of chronic disease. So mnemonic CETA for microcytic hypochromic type of anemia. So yes, MCV will be less than 80 femtoliter. MCH will also be low. So hemoglobin low, MCV low, MCH low. Next we will see what will happen to various levels of iron, ferritin, right? So what will you see? Serum iron will be low because there is iron deficiency anemia. Serum iron has to be low. This is a very important table and all the questions will be from this table only. Next, very important around which all the questions are asked, serum ferritin will be low. This is the most sensitive screening tool, right? So serum ferritin will be low in a case of iron deficiency anemia. What will happen to transferrin saturation, students? Again, very important. What will happen to the saturation? It will be low. There is deficiency of iron, so transferrin saturation will be low. Whereas the total iron binding capacity will be increased. So you come to a diagnosis of iron deficiency anemia, right? So what will be the values? Yes, MCV low, hemoglobin low definitely. MCH will be low. Serum iron will be low, right? Serum ferritin will be low, right? Transferrin saturation will be low, but total iron binding capacity will be increased. Now this is the table and you should be able to come to the conclusion of iron deficiency anemia in this patient. One important difference from anemia of chronic disease. Yes, we'll be dealing in detail when we are dealing with anemia of chronic disease, but here the serum ferritin will be high. Serum ferritin will be high in case of anemia of chronic disease, whereas iron deficiency anemia, it will be low. Very important. Frequently asked, right? Now, what are the important differential diagnoses of iron deficiency anemia? The causes of CETA, right? So, sideroblastic anemia, iron deficiency anemia, thalassemia minor, and anemia of chronic disease, right? So these are the questions from which everything about iron deficiency anemia is asked. Yes, low hemoglobin, low MCV, low MCH, serum iron low, serum ferritin low, transferrin saturation low, whereas total iron binding capacity will be increased. Now iron deficiency anemia is a type of hypoproliferative anemia. In fact, the most common cause of hypoproliferative anemia is iron deficiency anemia, which is characterized by a hypocellular bone marrow and low retic index. Low retic index. So I hope all the questions which are asked coming to a diagnosis of iron deficiency anemia, all the questions are revolving around the typical clinical presentation with the laboratory findings where serum iron, serum ferritin, transferrin saturation will be low, retic count will be low, but TIBC will be increased. very important differential of microcytic hypochromic anemia. Now, what do you mean by microcytosis? Yes, when the MCV is less than 80 femtoliter. What do you mean by hypochromia? Here, MCH will be low, and when you look at the peripheral blood film findings, what will you see? Number one, the size of the RBC will be less, right? So, microcytosis will be seen, very important. Microcytosis will be seen if you compare the size of these RBCs to the surrounding lymphocytes, small mature lymphocytes, they will be smaller in size. Number two, hypochromia. Normally, the central pallor present in every RBC is around 1/3 of the diameter. Whereas when it becomes more than half, that means the central pallor is increased in size, it becomes hypochromic. So when the central pallor becomes more than half, it is a case of hypochromia in the RBCs. So very important, microcytic hypochromic RBCs on peripheral blood film will be seen. Next will be, yes, platelet count will be increased. This is one of the causes of increased platelet count or thrombocytosis, right? So reactive cause of thrombocytosis due to iron deficiency anemia. Apart from that, anisopoikilocytosis. Anisocytosis is the variation in the size of the RBCs. Poikilocytosis is variation in the shape of the RBCs. Along with that, some abnormal forms of RBCs such as pencil cells can be seen. So till now we have studied about the clinical presentation, then we have discussed about the laboratory findings, then PVF findings. Last will be bone marrow aspiration. What will you see on bone marrow aspiration? Yes, you will see the presence of micronormoblast. You will see the presence of Now, how do these micronormoblasts look like? They will be small, right? So, there will be small pycnotic nucleus, with fraying of cytoplasmic borders, So, these will be the findings on your bone marrow aspiration. Is it clear? What will be the clinical features? What will be the laboratory findings, PVF findings? Bone marrow aspiration, micronormoblast will be seen, small pycnotic nucleus with fraying of cytoplasmic borders, whereas megaloblasts will just see in a megaloblastic anemia will be seen in megaloblastic anemia. How do they look like? We will discuss under vitamin B12 deficiency. Now, one important differential of iron deficiency anemia, if you remember, was thalassemia minor. So, we will quickly study about how can you differentiate between these two is Mentzner index, which is actually MCV by RBC count, right? So, in case of iron deficiency anemia, MCV will be low and RBC count will also be low, right? Because iron is deficient and thus RBCs are not getting enough amount of iron and thus the count will be low. So, the ratio of MCV by RBC will be less than 13. Mentzner index will be less than 13 in iron deficiency anemia. Whereas in thalassemia minor, MCV will be low because microcytic hypochromic anemia, but RBC count is relatively increased, right? So, the ratio will be more than 13. Mentzner ratio will be more than 13 in thalassemia minor. If I ask you which of these two will have a higher variation in shape and size, so RDW representing underlying anisocoilocytosis will be higher in case of iron deficiency anemia compared to thalassemia minor, where this RDW will be less. That means the variation will be lesser compared to a case of iron deficiency anemia. So I hope everything is clear. What all will be asked in iron deficiency anemia? Yes, the patient will be presenting with features of fatigue, right, tiredness, paleness of skin. Along with that, one important nail finding can be given, which is spoon-shaped nail, koilonychia. Right, koilonychia can be seen, that is a feature of severe iron deficiency anemia. Right, now apart from that, one important syndrome you need to remember is Plummer-Vinson syndrome, which is characterized by a triad. Right, what is the triad composed of? Yes, there will be iron deficiency anemia plus dysphagia plus atrophic glossitis. Right? Now, one important nail finding which is seen in B12 deficiency, which has been asked in your recent exams, will be hyperpigmentation of knuckles, which will be seen in case of B12 deficiency, right? Which will be seen in the case of B12 deficiency. We will study under megaloblastic anemia. So till now, all the features of iron deficiency anemia, I hope are clear to you. Iron metabolism, I will teach you when we are dealing with anemia of chronic disease, right?